Good morning, everyone. Thank you so much for the opportunity to present. As was mentioned, my name is Dorian Christmanson. I'm a fifth-year gynecology resident in Ottawa, Canada. This is my disclosure slide. So as we all know, pelvic floor dysfunction, including incontinence and prolapse, are prevalent women's health issues. Although not life-threatening, we know that they can significantly impact quality of life and increase morbidity. That being said, many women do not seek treatment for their conditions. There are many barriers to treatment, and these include lack of healthcare access, the common misperception that symptoms are normal or an expected part of aging, inadequate knowledge or biased information regarding the conditions or the treatments themselves, and finally, lack of decision-making support. Our study aimed to address these last two barriers. Decisional conflict can be thought of as a state of uncertainty when choosing between several viable treatment options. A high degree of decisional conflict leads to decisional delay or reversal, dissatisfaction with decision, regret, or even blaming healthcare providers for poor outcomes. Decisional conflict can be quantified using a validated scale called the Decisional Conflict Scale. This is an example of a scale that we used in our study. In Section A, women were asked to choose which treatment option they prefer. In this case, pelvic floor exercises or physiotherapy, pessary, surgery, or unsure. In Section B, they were asked to complete a series of 10 questions that allowed us to calculate the total decisional conflict scale. It also allows us to calculate 4 subscales reflecting patient knowledge about the condition, how clear they are about their values surrounding the decision, how supported they feel in making their decision, and how uncertain they are with the decision they've made. Decisional conflict is scored on a scale from 0 to 100, where scores more than 25 are associated with decisional delay or feeling unsure about implementing a decision. Our study population was women aged 18 years and older with incontinence and/or prolapse presenting for their first urogyne consultation. Exclusion criteria included anal incontinence, previous pelvic radiation, requirement for a substitute decision maker, inability to attend the workshop, non-English speaking, or an unwillingness to attend an English language workshop or to complete English language surveys. As this was a pilot study, our sample size was a convenience sample determined based on the anticipated number of new referrals. Over the 6 months that we recruited patients, there were 470 new referrals to our center, and we were able to achieve our target of 80 patients. In the end, 38 were randomized to the intervention group and 40 to the usual care group. So the intervention group was a 90-minute workshop on either incontinence or prolapse as chosen by the patient. It was facilitated by a nurse continence advisor and a psychologist. The first 15 minutes of the workshop was an information session on either incontinence or prolapse. The second 75 minutes was a guided discussion by the psychologist using motivational interviewing techniques. The control group was usual care and follow-up as planned by the urogynecologist. This is a flowchart that showed how women flowed through our study. So as mentioned, at baseline, we asked all women to complete a socio-demographic survey, as well as a baseline decisional conflict score. Women who attended the workshop were asked to complete a workshop evaluation immediately following the workshop. At a follow-up visit, all women were again asked to complete the decisional conflict scale. Our primary outcome was change in decisional conflict score from baseline to follow-up, and the secondary outcome was participant satisfaction with the workshop. Data was analyzed with an intention to treat model with paired t-tests and chi-square tests used as appropriate. So this table shows our baseline characteristics. I'll say off the bat there was no significant difference between groups at baseline. On average, our patients were in their mid-50s, were predominantly Caucasian, educated, and the most prevalent pelvic floor diagnosis was incontinence, followed by prolapse and incontinence. This table shows the baseline decisional conflict score. There were no significant differences between groups in terms of the total score or the 4 subscores. This graph shows our primary outcome, which was again change in decisional conflict from baseline to follow-up. On the x-axis is the total score as well as the 4 subscores, and the y-axis is change in decisional conflict as reflected in a negative number from baseline to follow-up. The dark bars are the workshop group, and the light bars are the usual care group. We can see that in the total score, there was a significantly greater change in the women who attended the workshop compared to those who attended usual care. In terms of the workshop evaluation, patients were uniformly quite satisfied with the workshop. They felt comfortable with the group size and comfortable discussing these topics in a group setting, and the vast majority of them would recommend this workshop to a friend or family member. About 3/4 of them said the discussion brought out feelings they would not have discussed otherwise with their physician, and only 30% of them said, "I would prefer to discuss these issues alone with my doctor." So in terms of the strengths of our study, the randomized design and the use of a validated questionnaire added to the quality of the study. In terms of limitations, there was some degree of loss to follow-up as the study progressed, as well as an element of selection bias in that women who chose to participate in the study may have benefited more from the intervention. So in conclusion, what this pilot study has shown is that participation in a group workshop reduces decisional conflict in women with incontinence and prolapse. Furthermore, we found that this workshop was satisfactory to women. Our future directions include developing a fully powered study with longer-term follow-up data on decisional implementation, satisfaction, and regret with their decision, along with a possible cost analysis. Thank you very much.
Any questions on the floor? Do you have any data about the cost effectiveness of this?
We don't. That would be what we're interested in looking at next. I think that if this was funded by an educational grant, I think if we could show that there was a cost in terms of reducing costs to the hospital, to the system, I think we could make an argument for implementing a program like this within our health region.
Thank you. Thank you. Okay. Thank you for your presentation.